Thanks, everyone. So before I start, I have to say that this trial is a result of all the hard work of all of you who recruited, enrolled patients, put them into the trial, and enrolled them under very difficult circumstances. And we'll come on to that in a second, because the patients who were picked for the patch trial were critically injured. And as you can see in the top left of your screen there, these patients are not sitting in an ICU with someone with a clipboard enrolling them. They're enrolled while they're being treated, resuscitated, extricated, and then brought to hospital. And then not every major trauma centre in Sydney was a participating centre. So there was some layers of complexity to this trial. And what I'm going to do is I'm going to present the trial and then leave plenty of time for discussion. So these are the results of the pre-hospital antifibrinolytics for traumatic coagulopathy and hemorrhage, or the patch trauma trial. And this essentially is the result of 10 years of work, 3 years of planning, and then 6 years of running the trial, and then a year of data analysis, follow-up, and then publication. And this was supported by the NHMRC in 2 grants, and it was run by ANZICS and down through Melbourne, essentially. So run by the patch study investigators and the ANZICS clinical trials group. Hopefully I can move on to the next slide. Okay, so this has been published in New England Journal of Medicine a couple of weeks ago. It is creating some interesting discussion and some really good blogs on this, and I'll post them up on the WhatsApp, but there's been some really good discussion around this. It'll be interesting to see what people think here. So the aim of this trial was to evaluate the efficacy and safety of tranexamic acid in patients with severe trauma who are at risk of acute traumatic coagulopathy. And that's quite important to bear in mind. They didn't have proven coagulopathy of trauma, but they were at risk of having it. And we'll talk about how we decided that. And they were being treated in an advanced trauma system such as Australia. Okay, so just a reminder about tranexamic acid. It's a lysine analog, so it essentially competes with at the fibrin level and stops fibrinolysis. So it inhibits the conversion of plasminogen to plasmin. Plasmin obviously breaks down fibrin, which is bad, but also plasmin does cause neurotoxicity, and it does cause. Sorry.
Taking place now in the education centre. Please feel free to
sorry.
For if available. Thank you.
Okay, so plasmin can actually cause neurotoxicity and inflammation, and there is a feeling among the community who are research TXA that its effect is not just through antifibrinolysis and clot breakdown, but actually through neuron protection and through its anti-inflammatory response. All right, so there are some trials out there, some stuff out there, a lot of studies on TXA in elective surgery and reducing bleeding. I've just been up in a cardiac theatre, and TXA was being given to the patient like no tomorrow. It's been given a lot in cardiac surgery. It's being given a lot also in non-cardiac surgery. And if you look at on the left of your screen there, this is a risk ratio in all kinds of elective surgery. This essentially was a systematic review, and you can see heavily favoring tranexamic acid on the left there in elective surgery. So in terms of trauma or bleeding related to injury, we are all very familiar with the CRASH-2 study, which showed 28-day survival benefit in trauma patients at risk of bleeding when given within 3 hours. It was a really well done study. It enrolled 20,000 patients. Simple inclusion criteria of systolic less than 90 or heart rate over 100. So you could argue, you know, if you broke your tibia, your heart rate might be over 100 and you could potentially get enrolled into this study. And it was an in-hospital treatment, so not pre-hospital, and they got 1 gram of TXA as a bolus, and then they got 1 gram infusion over 8 hours, or they got placebo. So the 28-day mortality was TXA 14.5%, placebo 16%, and you can see the risk reduction there, 0.91, a confidence interval that does not cross 1 and was significant. So essentially saves lives with the number needed to treat of about 67. Now, in terms of deaths due to bleeding, again, had effect So you can see there yourself, TXA favored placebo over placebo, and vascular occlusive events were essentially about the same in both groups. Now, having said that, in CRASH 2, there was not a lot of follow-up in terms of VTE, in terms of screening, either through Doppler or through interventions such as CTPA, if required. CRASH 2 enrollments for most patients occurred in countries yet to implement region-wide or hub and spoke trauma systems. And if you just look through that bar chart, you'll see where most of the patients came from. So most of them came from low, medium human development index countries, and 6,000 came from high, and a very small number came from very high. Australia would be considered very high. So when we look at that, and then we look at how the trauma systems have advanced around the world, certainly from about 2006 onwards, the UK trauma system really developed, and that decreased mortality in trauma over time. This is a review that was done, or a process review that was done in Victoria, where from 2001 they redeveloped that region-wide or hub and spoke trauma system and decreased mortality year on year over the 10 years. So there was a group of us that felt there was some equipoise in looking at TXA being used in advanced trauma systems where you get access to pre-hospital advanced resuscitation, blood products, in-hospital angioembolization, hemorrhage control by surgeons, and then Dopplers and follow-up. In terms of subsequent trials of TXA and trauma, we all know about CRASH 3, primary outcome in terms of 28-day TBI-related death, no significant difference, and no association of vascular occlusion either. The ROC study that was done in the United States looked at moderate to severe TBI. It looked at an outcome functional level GOSE of greater than 4, being good, and they gave either 1 gram plus 1 gram, or versus 2 grams and no grams, or 0 and 0, i.e. placebo, within 2 hours of injury. And essentially TXA 65% and the placebo 62%, no significant difference in 28-day mortality or 6-month disability. STAMP trial we're all aware of was done in the United States. Again, simple pragmatic enrollment criteria, systolic less than 90 or heart rate over 110. And they either got placebo or 1 or 2 or 3 grams within 2 hours. And with TXA, 30-day mortality was 8.1 versus 9.9, not significant. In terms of vascular occlusive events, generally speaking, there's a feeling that, whoops, I'm not sure what happened there. Sorry, it's just gone. Can you see it still? Yeah. Yeah, it's back. Okay, sorry. In terms of vascular occlusive events, the TAMPETI trial and then the HALTED trial, which you'll recall is a TXA study in GI bleeding. There was no my little thing here. Oh, there you go. There was an increase in TXA in that HALTED trial in terms of VTE with a relative risk of 1.85. And again, in terms of vascular occlusion in the TAMPETI trial, you can see as the dose goes up, the risk of VTE increases. All right, so there's been variable uptake of TXA around the world. Certainly, in the UK, Europe, Australia, there's generally been quite a large uptake, particularly by retrieval services. So not many of the ambulance services have actually taken this up yet. And this is something that the ambulance services may need to decide soon as to what they're going to do. And hopefully this trial will help with that. You can see here, these are data from EMS agencies around the world who responded to a survey. Not all of them responded, but you can see in the dark black kind of gray color, these are statewide trauma protocols with TXA. The reddish color is statewide protocols without TXA, and then the ones in yellow don't have any protocol for EMS whatsoever. All right, so this trial was run in 36 services in 3 countries, and you can see there different states came on at different times. So Victoria came on first. We had some challenges in terms of ethics in New South Wales, but we came on later, and we managed to enroll a high proportion per the time that we were involved in the study, and Northern Territory's involved, and then New Zealand was involved. This has been the largest Australian and New Zealand kind of quasi-national, I suppose, or international study involving those two countries ever done on trauma. Western Australia was not involved, and ACT was not involved. Germany came in towards the end of the study in Frankfurt and recruited only a few patients that came in right at the end. So the study design, many of you were involved, was quite pragmatic, quite simple. So it was patients were screened at the scene of injury, and at that point they were randomized. And if with the randomization, they would open a tamper-proof pack, which you can see up in the top right there. And they would there were two ampules in that pack, blinded, and they got 1 gram stat or over 10 minutes, and then that other ampule was handed to the trauma center, and they would give that over an 8-hour infusion, or they got placebo plus placebo. There was some blood tests done based on arrival, and also at 8 hours post infusion and 8 hours post infusion, and then 24 hours post bolus. And then they had between days 5 and 7 DVT, ultrasound, and then at 6 months there was a telephone follow-up, and I'll talk about that shortly, but it was done by trained people in the V-Storm Trauma Registry in Victoria who have been doing this for a long time, where they run the patient or the proxy or the carer through a validated questionnaire to find out how their functional outcome is. So inclusion criteria were patients over or equal to the age of 18, injury through any mechanism, at risk of ATC or coagulopathy of trauma. They had to have a co-score greater or equal to 3, and the first dose of the study drug had to be administered within 3 hours of injury, which most of our patients would meet those criteria. And then the intended transport was to a participating trauma center. Exclusion criteria were the usual caveats that occur with trials such as nursing home residence and suspected pregnancy. This is the co-score, and it's highly specific for coagulopathy of trauma, and it does correlate with mortality and predicts coagulopathy, so it's about 96% specific, but it's not sensitive. So there are plenty of patients who are coagulopathic who don't who have a co-score of less than 3. And when we say coagulopathy, it's a crude marker, but in the studies it's picked as an INR over 1.5. You can see the variables there. Some of them are subjective, some of them are objective. So blood pressure, temperature, etc. don't lie. If you're trapped in a vehicle, that's pretty obvious. But the last two are certainly clinical subjective things, like major chest injury, likely to require intervention at some time in terms of decompression, or likely interpelvic or intra-abdominal injury. And in our setting with ultrasound, a positive fast scan, be it pneumothorax or free fluid in the abdomen, would get you a point. So this is the primary outcome measure. The primary outcome were the proportion of patients who survived with a favorable functional outcome at 6 months compared to those who died or have severe disability. And the reason this was picked was we felt that it allows room for the non-fibrinolytic effects of TXA that may affect recovery. Obviously, there's an anti-fibrinolytic effect to improve immediate, blood loss and survival, but there's certainly interest in the anti-inflammatory neuron protection effect. This was assessed using the Glasgow Outcome Score Extended, or GOSE. This is favoured for trauma registries. It's responsive or works in both traumatic brain injury and non-traumatic brain injury patients. It can be administered by a proxy or a next of kin, and incorporates most of the dimensions of WHO International Classification of Functioning Disability and Health. And it was, like I said earlier, it was done by a standardized questionnaire by trained telephone interviewers. Don't have to look at this too much, but essentially 1 is dead, 8 is upper good recovery, no problems, totally back functioning and independent. Where the cutoff was in this, a dichotomized, was between 5 and 4. So 4 is dependent on others for some activities. and 5 is independent at home, can go outside, but with some physical or mental disability, but unable to go to work. So 5 we considered okay, but they can't go to work. 4 and below, they're not at work, they're at home and dependent on others in various levels, or they're vegetative. We did have some pre-specified subgroup analyses on age, mechanism of injury, systolic blood pressure, conscious state, in terms of GCS, time to treatment. And then we looked at some additional measures to account for the potential influence of TBI on the primary outcome. And I think this is quite important in trauma trials where severe brain injury can muddy the waters in outcomes. So we stratified the randomization based on GCS of 8 or less, or 9 and above. And that, you'll remember, that was based on the 2 different colors of the tamper-proof packets, either red for GCS less than 9 or yellow for GCS 9 and above. We also did a post hoc analysis on the abbreviated injury scale for head injury. So that's a measure that's used after we get all the information in hospital in terms of their GCS and what the head CT shows. Can't be done pre-hospital. And it goes from 1 to 6. 6 is unsurvivable head injury. So it was based on analysis of that. Lots of secondary outcomes. Mortality at 24 hours, 28 days, 6 months, cause of death, vascular occlusive events, sepsis, blood products use, coagulation profile. There wasn't much thromboelastography going on during the time period of the trial, but there were some patients who did have that, but it wasn't measured. ICU ventilator-free days, and then quality of life follow-up at 6 months. So the study was designed to have a 90% power to detect an increase of 60 to 69%, so a 9% difference of patients with a favorable functional outcome. There was an observed loss to follow-up during the trial of 10%, and this increased the target sample size in 2020 from 1184 to 1316. The primary analysis was intention to treat without imputation or regression for missing data, and there was some additional analysis done to account for missing primary and secondary outcomes. And there was supplementary analysis accounting for location of enrollment in GCS. We also did a per protocol analysis for patients for patients who were, to allow for patients excluded who were enrolled and found not to meet inclusion-exclusion criteria, or who didn't receive both boluses of the drug or received open label TXA. So this is randomization. We had 1,310 patients who were enrolled. We only had 3 packs lost in the field, which I think is a testament to the pre-hospital services involved, because that's quite good. We got 661 in each in TXA, 646. Some withdrew consent for use of data, but all in all, we had an equal number in the intention to treat population. Some withdrew consent on the 6-month follow-up, and we had some lost to follow-up, which is not unusual in pragmatic trauma trials. But we did have primary outcome data for 572 in TXA and 559 in the primary outcome data available at 6 months for the placebo. All right, so you can see here the protocol deviations. And so the big ones to point out are received the first dose of the study drug only, about 21%, 25% in each group. So that's quite a high number. And then we have received open label TXA, about 16% in each group. Again, it was equal in each group. And certainly, we're already using TXA in Australia, particularly in trauma centres. So that's where a clinician felt, I'm going to give open label TXA, often in theatre. So any protocol deviation, which is a combination of them all, was about 30%, 32% in TXA, 37% in placebo. These are the patient characteristics, and you can see it follows what we usually expect in trauma. You've got, male, predominantly male pattern of 70% male, patients generally in their 40s. Blunt trauma accounts for 92, 93% of patients. That would be very different in the United States, where it's more like 60-40 or 50-50. Median heart rate, 110. And then the initial systolic blood pressure, you can see there the bands of blood pressure, quite a sick population. 3/4 of them had blood pressure under 90, and 40% of them had a systolic blood pressure less than 75. And you can see there the spread of Glasgow Coma score. So patients with severe injury, GCS less than 9, in terms of head, about a third of them. And then mild head injury, about 57%, and then moderate and in between. Pro score you can see there, I won't go through that. The important point to point out here is the median injury severity score was 29, which is quite which has picked out the appropriate patient population that we're interested in. We know as your ISS goes up or your injury severity goes up, your likelihood of coagulopathy of trauma goes up. So we did identify the right patient population. Severe injury is defined as an ISS over 15. For a score greater than 2, so quite bad heads for AIS for the head, made up about 40% in each arm. And we won't need to go through the various different blood products that we use, but I will draw your attention to the bottom of the slide. And then from time of injury to first dose of TXA or placebo, about a third got it in under an hour, and 45% got it in 1 to less than 2 hours, and then 20% got it in over 2 hours, but less than 3. Right, so this is the primary outcome for the patient. So survival with favorable outcome at 6 months in the TXA group was 53.7%, and a placebo was 53.5, with a relative risk ratio of exactly 1. So essentially there was no benefit in terms of that primary outcome measure of TXA versus placebo in terms of functional outcome, favorable functional outcome at 6 months. Now, if you look at this slide, you can see the black line. That dichotomizes the outcomes that we mentioned from 4, upper severe disability, and 5 being in green, lower moderate disability. If you saw a big difference, those lines would be quite separate. But in terms of unfavorable functional outcome, you can see, if you look at the far left in terms of death, less patients died in the TXA group than in the placebo group. But there are more patients in that left-hand side in general of poor outcome in terms of unfavorable functional outcome. So more survived, but there was slightly more patients had worse functional outcome. So if we look at down the left is placebo better, and on the right is tranexamic acid better. If the confidence interval crossed that vertical line in the middle, there's no difference. So if you look through the age groups, time to drug dose, there's no real difference. But you can see there's a signal that if you give that TXA over 2 hours from the injury, you're heading towards a signal that placebo is better. And certainly in CRASH 2, we know that given over 3 hours from injury, TXA caused harm. Again, spread of blood pressure is no difference. There's a very low number of penetrating patients in this group, but it seemed to favor TXA, although not statistically significant. And then in terms of GCS, initial GCS less than 9 looked like it was favoring TXA again, but it crossed 1 compared to over 9. And then if we look at injury severity score for the head, when we actually not just have GCS, but actually have their anatomical injury in the brain from CT, you can see there that if you're moderately injured head, so less than or equal to 2, it seems to favor TXA. But if you're severely injured head over 2, it looks like it's heading towards favoring placebo, or as in TXA doesn't have any effect. These are the secondary outcomes in terms of mortality. Now, 24 hours after injury, 9.7% of TXA patients were alive, died, versus 14.1% in placebo. So there is a difference. So more patients will survive the first 24 hours after injury if they get tranexamic acid. The same is said for 28 days after injury. You can see the risk reductions there on the right. Having said that, at 6 months after injury, that becomes insignificant in terms of death, and the confidence interval, 95% confidence interval, crosses 1. In terms of death within 6 months after injury due to bleeding, you can see there for yourselves bleeding, vascular occlusive events. The key thing there is vascular occlusive events did not have any difference between the two groups. So it is safe from that point of view. And there was no other difference in terms of traumatic brain injury, other causes are the same. This is the separation. So this is Kaplan-Meier curve separating. Placebo is in blue and TXA is in red. And you can see over time, the mortality separation is quite early on and remains. Again, we talked about the adverse events. The key thing here is that there was no big difference in sepsis or in DVT, myocardial infarction, etc., between the two groups. So, in conclusion, and I've kept this fairly short so we can have. I haven't drawn my own views yet on this. I'd be interested to hear people's views and questions. But in conclusion, these were our conclusions in the paper. In adults with major trauma at risk of ATC, there was no significant difference in survival between favorable functional outcome at 6 months between the TXA group and the placebo group. So in our trial, for every 100 patients allocated to TXA rather than placebo, you got 4 extra survivors alive at 6 months. However, there was also approximately 4 extra survivors categorized as having severe disability. They're not necessarily the same patients who survived. And there is little evidence that TXA increased vascular occlusive events. So I'll stop there and leave it open to questions and discussion.
Thanks very much, Bran, for that presentation. Has it got any questions in the room?
Hi, Brian. It's Robbie here.
Hi, Robbie.
So you may have already explained this, so forgive me if that's the case, but if you change the definition of a favourable outcome, and so you make it that if you are dependent at home but still somewhat functional, I think that was deemed to be an unfavourable outcome. Does that change the primary outcome result?
I don't know. We didn't look at that. The dichotomy we used is fairly well described in terms of those two groups. They could argue we allowed 5 to be called favourable, but that's where you're at home and you do not go back to work. So you have to kind of ask yourselves, is that something you would want for yourself? And I think the tricky bit about this study is that a bit like the paramedic 2 trial and the adrenaline trial, you had more survivors with adrenaline, but worse, an increased number of non-neurologically intact survivors. But they did a really neat thing in that study is they asked the population what they would prefer, and they would not prefer to be left in that state. Now, having said that, this is not black and white, this study, and it'll ask more questions than answer, I think. But I do wonder what the patient or what the population would want, or what we think we should do. There's a definite mortality benefit very early on, and we didn't have the early on Kaplan-Meier curve, but in that Kaplan-Meier curve separates in the first number of hours. That could not be from antifibrinolytic effect or from stopping bleeding. There's no way that one dose of TXA is going to stop you hemorrhaging to death. So there must be some anti-inflammatory neuron protection or something going on that's related to plasmin inhibition. Is how I see it. But yeah, I think our primary role as pre-hospital clinicians, as doctors in ED or in anesthesia and trauma, is to keep people alive. So it certainly does that. But the question is, are we doing the right thing? And do we need to look at, I don't know, doing something else or a bigger study? I'm not sure. Alex.
Hey, Professor. Well done, man. Yeah, just a massive trial. I mean, 2 things. the sort of the mortality benefits that you're seeing across a lot of these studies, or the outcome benefits, are sort of 1 or 2%, and that's actually in the ballpark of CRASH 2, except they just had 20,000 patients, so it probably did meet statistical significance. And that there's always the chance that it does in fact have this sort of consistently very small positive effect. But that's sort of neither here or there. I guess the other question is, when you've got 20 to 30% of protocol violations, I might have missed it, but what was your per protocol effects? Did they change significantly?
Really good question. So we did an imputation. So the statisticians did regression and imputation for missing data on the intention to treat, and there was no difference. But they also did a per protocol analysis, and there was no difference. So both analyses, there was no difference. Now there were missing patients, as you say, but in terms of our analysis, we couldn't show any difference. One of the interesting things, and I've been reading some of the blogs around this, is I think one of the weaknesses of this study is we did not have consecutive patients. So in other words, when you enroll a patient, you ideally enroll one after the next, that no one gets left out, or at least gets enrolled where it's feasible. Patients were definitely left out, and we tried to keep a log on that nationally, but we couldn't. So clinicians, either with their own bias, potentially would have excluded severely injured, or even more severely injured, because they felt, I'm going to give this person the kitchen sink, and that is their right if they don't feel there's equipoise, or their bandwidth was saturated and they didn't think of it. So I think from my surveillance of the trial in New South Wales, I think that was the general reason patients were missed, either through bandwidth saturation or severe injury, and they felt, I'm going to give this drug, which is the same as would have occurred in theatre, I think, with some of these patients who would have been given open label TXA. My main question for people online, and it's been discussed a lot, this study, is, and actually if you look at the mortality difference between the two groups, the number needed to treat in our group is actually quite small. It's about 20. They're quite badly injured patients, but it's about 24 or something, or 22 to improve mortality. And if you feel strongly that's our primary role, and that in-hospital treatment will constantly improve, rehab will improve, then maybe that's good enough, and we'll improve those processes as we go along in development of the system, and we can fix that later. I think I'd be interested to think what most people's views are on what you think we should be going forward, or if you were a medical director of an ambulance service, what you would recommend to do within your ambulance service, or if you're a lead paramedic, what would you recommend? I'd be interested to hear people's thoughts.
Anyone? We don't have much coming through online, whether you've got something on there, but certainly in the room, and from what I've been reading, around the response to this trial, is certainly that, I guess, with the administration of tranexamic acid and the mortality benefit is, as you say, that you need to survive in order to be able to get to those long-term outcomes, and then with adding in rehab, and as those services continue to improve, I think perhaps there's a feeling of still administering TXA in the hope that you can get to that long-term mortality benefit, and hopefully that it highlights the need for improvement in that area, as well as the initial resuscitation.
Yeah, thanks, Brian. It's Tristy. Having read a bit of commentary on Twitter, and I think a poll went up, like, are you still going to use TXA given the results of this trial? I think that's really interesting. It'd actually be interesting to post a WhatsApp poll on our big group. That I'm definitely on the side that this was a positive trial for us pre-hospital, and TXA works. Yes, there's big numbers needed to treat, but like you say, it's very difficult for us to quantify in a helicopter on the way to hospital what's going to happen in the next 6 months, and what advances in care are going to happen in that time. So I'm very much on that side of the fence. Out of interest, so there were 4 extra people with severe disability in that coming 6 months, and that was traumatic brain injury and non-traumatic brain injury groups were separated. What was
Yes.
causing the severe injury and disability if it wasn't a brain injury?
So that another paper will come out with that in finer detail. It's a good question. So actually, I'll just show you another slide. And let me just bring up this keynote again. This wasn't in the primary paper, so some of the stuff isn't in the primary paper. So can you see that okay?
Yep.
Yeah, okay. So you've got up the top there, that group, you've got AIS or head less than or equal to 2. So head's not bad. Then the bottom group, head's bad. And you can see there yourselves, if you look at, interestingly in that group, if you look at dead in kind of brown, TXA 32% dead, placebo 35% dead. So you've got again improved survival in severe heads from TXA. But if you look at that dial or needle of where we did the dichotomy of the severe disability versus not more favorable, you can see that it's worse in the TXA group if you've got a severe brain injury. And that's certainly what came through in CRASH 3 as well. So in my mind, I definitely, in severe brain injury, isolated, I don't necessarily think it's a good thing to give patients, but it's very hard for us to tell pre-hospital if they fit that, if they are severely head injured when they're potentially severely shocked, hypotensive, causing decreased perfusion to their brain, and that's why their GCS is low. So that's a real challenge, I think, for us. I don't think we can separate them out. I don't think we're going to be able to isolate severe brain injury out from multi-trauma, given the main mechanism that we have in New South Wales and Australia is blunt trauma. It's not like a bullet to the head. But yeah, that's how it's currently standing when you look at severe brain injury.
Yeah, that's really interesting. The other comment that was interesting was about that, what's it called, paramedic trial, the adrenaline.
Paramedic 2, yeah.
Paramedic 2. The public opinion was that they wouldn't want to be in a vegetative state post-cardiac arrest. I really wonder if that does translate to the trauma population being younger, fit, well people versus the patients that were having cardiac arrest. I tend to think that the opinion of families and loved ones of the young trauma patients we treat might be different to that, and their opinion of having a GOS E4 surviving relative might be seen as a positive, rather than splitting that those groups right where we did might be different.
I agree with that. So I think that's a very important point. A lot of patients in cardiac arrest in paramedic 2 would have been an older population. They would have gone, yeah, I don't want to carry on like in this state. And you're right. And again, trauma is one of those difficult illnesses in that usually the person is pretty healthy or just going along doing whatever they're doing. And then all of a sudden there's a huge perturbation to their system and they're severely injured, versus someone who's got chronic comorbidities and ends up having a myocardial infarction and a cardiac arrest. So I agree. And I do think most patients would want a bite of the cherry, even that notwithstanding unclear as to whether it's going to end up in a favorable outcome. I think mortality improvement initially in those first 24 hours, 28 days, whatever it is probably enough for the general population, I imagine. I do wonder about the timing, because we are certainly now showing a signal that over 2 hours is not particularly good. So my question I would have for our service is whether we should bring that number down to under 2 hours of injury rather than less than 3. It's semantics. The other thing just to mention is not many places are doing the single bolus dose and then the infusion anymore. And there is some interest and some research going on in the 2-gram dose. But the concern is potentially about vascular occlusive events. But that ROC study did not show any benefit with that dose or the stamp, but it's something I think also worth looking at instead of a 1-gram dose. Not sure.
that touches on, Brian, some of the comments online that have just come through. Mark asking about whether your study showed that earlier administration of TXA within 1 hour, whether that demonstrates a difference for the administration times. And oh, sorry, I'll let you go on.
Keep going. No, keep going. I'll just bring up this slide again.
Yeah, that's it. Mark had sort of mentioned that some analysts of TXA studies have demonstrated an improvement with earlier administration and potentially that increased dose as well that you mentioned. And Sarah's also mentioned the discussion around providing paramedics on the road with TXA to administer for that earlier administration to trauma patients, but and also PPH, but noting that it's for discussion at the moment rather than for decision. But wondering your thoughts on that.
Yeah. So these are interesting. So the woman trial, which was a TXA study, didn't show any benefit. The halted trial, I think, has its problems in that clinicians were allowed to exclude patients who are severely bleeding with GI bleeding. So actually, they're the patient population I'd be most interested in terms of GI bleeding. But if you look at I think Sarah's questions and points are a good one, because if you look at these numbers, you've got less than 1 hour, seems to be, around the same between the two groups, but 1 and less than 2 hours looks like it's favoring TXA. You can see it's kind of moving the dial to the right, but over 2 hours is moving that dial to placebo. So certainly I think in the rural and regional setting, I don't see any reason why New South Wales ambulance paramedics should not be giving this drug for those patients who meet those criteria. The co-score has plenty of skeptics, and it's not sensitive, but it's specific. So, and it's a very easily administered score. So, and that's why it can be done in terms of services introduction of TXA. So potentially, if a patient has a co-score 3 or more and they're in Walgett at the side of the road while aeromedical are on the way, it would seem reasonable to me that they would get the dose if it's under 2 hours from injury.